Insulin therapy in diabetes is there to stay for many, many more years. Because in type 1 diabetes, until we find a way to really stop the immune system from destroying the insulin-producing beta cell, we will have a need for insulin there. Also in type 2 diabetes, an integral part of the pathology of type 2 diabetes is the failing beta cell. And until now, we have to be honest that even with the new interventions like GLP-1 receptor agonists, although having promise in animal models, we have not seen clear signs in humans that we can alter the fate of the insulin-producing beta cell. So until now, we have no agents in type 2 diabetes that really can prevent the failure of the beta cell. And so if we treat our patients good enough by glucose treatment, by lowering blood pressure, by treating the lipids, by doing all of these things and let them live long enough, most of our patients at a certain moment will need insulin. So insulin, I think, is there to stay in all forms of diabetes. So it is important to make progress also in that field, although it's perhaps a little bit less sexy than all the novel agents we're seeing coming. But what is evolving? We're getting better basal insulins that are that have a more stable profile, that have a longer profile, and thus are reflecting less hypoglycemia, in particular less nocturnal hypoglycemia than the older basal insulins. We're also having incremental improvements in mealtime insulins. We're having mealtime insulins that are more rapid in onset and rapid in offset, and does allow us to mimic better the glucose excursions that we see at meals. So better basal, better mealtime insulins, better combinatorial insulins also, namely insulins where a basal insulin and a mealtime insulin are coming together without affecting each other's profile. We also have combinations of basal insulin and GLP-1 receptor agonists in one pen. We have Iglar-Lixi, we have Ideglira. Very interesting components that are now being explored in people with type 2 diabetes and prove tremendously efficacious in, again, not only lowering glucose, but also having an effect on body weight and on hypoglycemic risk. And of course, the holy grail will be if we can get an insulin that is smart, namely an insulin that will only work when it's needed, so only work when glucose goes up. A lot of research is still ongoing there, some of it presented at the ADA, but we have to be honest, it still seems a very long distant goal at the moment. And so at the moment we're really looking at incremental steps. The message for all doctors is really keep diabetes in perspective. Be aggressive when treating diabetes. People with type 1 diabetes should be very well accompanied in their therapy. They need to be in charge of their disease, and so they need to be helped not only by doctors but also by educators and by good tools that we have now. But especially in type 2 diabetes, we have to be more aggressive, more early in our treatment. We have to find the people at risk and take them on for their health risk early on. Indeed, we need not only to treat the glucose, but also look at the blood pressure, the lipids, etc. So specifically for young diabetologists, I think you're in business, because there's a growing number of people with type 2 diabetes, but also a growing number of people with metabolic disease. Not only type 2, but also NASH, also cardiac problems, also renal problems. And it's really, I think, the diabetologists that are very well placed in playing a central role in this holistic approach of these people with type 2 diabetes. So all people who want to become a diabetologist, I think it's a very good bet for your professional career to become a diabetologist.